Okay? Oops. Why it's called oops, I'll show you in a second. It's, again, a 32-year-old male, fairly young, who had a long QT syndrome and survived sudden cardiac death. So he's a so-called sudden cardiac death survivor. And very dramatic. Can't remember the exact details of how he was found and resuscitated, but after that, obviously, the treatment of choice is a defibrillator, implantable ICD. So that was fine. He was doing okay, and then all of a sudden he started developing SVTs, very rapid SVTs, which were a burden to him. And he went from one doctor to the other, cardiologist, and finally someone said, you know, the only way we can really treat this is to give you some form of EPS and electrophysiological treatment. So he was sent to ablation, and I will show you what we found on the echo that we did before we performed the ablation procedure. At least in our institution, we perform an echo or a T study in all patients before we do the ablation, simply because we want to rule out a thrombus, and this was exactly the reason we did this study. Here is now the transthoracic study. Okay. Okay, nothing really unusual here. Short axis view, another short axis view. 4-chamber view. Here you can see the defibrillator in place. Left ventricle function is okay. Okay, I just want to show you this one loop, which is, you can see he has ectopic beats, irregular rhythm, and there was one loop where he actually had a tachycardia during recording of the echo. But you would agree with me that aside from the fact that his left ventricle function looks kind of awkward, which can be related to the ectopic beats, nothing really abnormal was found. The aortic valve was okay, mitral valve was okay. Okay, so we went on to perform a TE study, and this is the TE study. This is the left atrial appendage, aortic valve. Right here you see the left atrial appendage. I think we should have a better view somewhere. In any case, I think you all agree that there is no thrombus inside. Now this is the intraatrial septum we're seeing here. This is the aortic valve. Okay, I do not want to take too much of your time, but this is now the inflow-outflow tract of the left, excuse me, the bicaval view, of course, cava superior and inferior. Those are the leads here that you see. Okay, I'm not going to say too much about this image. Just take a look at it for a second. Here's another view. And another one. And another one. You can tell that we're really looking closely at this area. And another one. And then we used color. And we used color again. Just a tip for all of you who do TE studies. If you want to see a patent foramen ovale, you can do that with color Doppler very nicely. Very, very nicely. The only thing you have to do is you have to bring down the PRF limits here so that you have more turbulent flow across the PFO, right? And the region that we're looking at is right here. Okay? Good. Again, another view and another view. Okay. I think it's time for a question. Oliver, can you put the question up? Again, what is the problem here? Does the patient have a patent foramen ovale? I mean, would that really make a difference for the procedure or not? Is there a thrombus or some vegetation or who knows what on the leads? Or is maybe the lead somehow misplaced? I don't know. Or maybe are all of them correct? Half of you have voted already. This is a, you know, I know I'm showing very complex cases today. The last one that I want to show you will be a simple case that just shows you how to perform an echo in a patient who has a disease. But I did want to show you this patient because it's a fairly spectacular kind of a case. Okay, let's close the poll. Okay, 30% think it's a patent foramen ovale, 16% think it's a thrombus or vegetation, 28% think it's misplacement of the lead, and 26% think it's all of the above. Well, everyone who answered was at least partially correct, because the right answer is all of the above. Let me go through these studies again and show you what we saw. Okay. Superior vena cava, look at the structure here. This is moving here. There's something here attached to the leads. I will show this in a slow-mo. Here you can see this is a structure which is probably on the lead. And there's another view that shows that even nicer, I think, here. It's very difficult to really find these structures even in a TE study. But here it was kind of obvious, because fortunately the region where the structures are nicely visible. It's the proximal portions, right where the leads come into the right atrium, are very nicely visible. And you see that there is a long vegetation, probably even starting from here right down to here. Well, vegetation or thrombus, actually, because at that point we personally did not know what it was, but it turned out that the patient also had an infection at the time. So my suspicion was that this is actually some form of endocarditis. Okay, then there's another thrombus here, but this is not the only finding. The other finding that you can see is that, look at this lead here. This lead is passing right through the interatrial septum via the foramen ovale. And this is the tip of the atrial lead. It's right here in the left atrium. So that means the PFO has to be open. Otherwise, you could not get through unless you would just, punch it through, which I don't think. And the patient has lead misplacement, and the patient has some form of vegetation or thrombus on the leads. Okay, now this gives a completely different spin to this case, simply because couldn't this be the cause for his supraventricular tachycardia? Somehow the leads are distracting the electrophysiology of the atria. We discussed that with the electrophysiologists, and they said, well, before we do any form of ablation, we have to remove this, and we have to figure out if SVTs are still present or not. And then the question was, should we just simply pull them out, or should we just operate on the patient and open the heart and take them out then? Well, this is the question. The answer is not so easy to give, but in reality it depends very much, obviously, on the size of these vegetations and if the patent foramen ovale is open. Because if it is really open, it could be a possibility that these vegetations simply are dislodged into the left atrium, and then the patient has some form of a stroke. Well, we went on and off, and eventually what was done was they were just retracted surgically, and the diagnosis of vegetations were confirmed, and the patient was then rehabilitated after the operation, and so far he did not have any SVTs anymore. So I guess this was his main problem. Okay, so thank God this time everything went fine and everything went good. But it does show you that implantation of defibrillators, especially in young patients, is not, such a, it's a decision you have to make, which does have its consequences. Good.